All right. Hello again, and welcome to another Down Fracture podcast, a podcast for talking jaws. Dr. Michael Wasson here with Dr. Sam Bobek. What's going on, Sam?
Not much. It's good to see you. We're both wearing scrubs this morning, huh?
Yeah, I actually have to do some work today. How about you?
Same thing.
Huh.
Yeah, it's pretty exciting. What you got there? A little coffee?
A little coffee. Yeah.
What's Arizona coffee like? Pretty good, terrible, in between.
It's probably pretty in between.
All
I
right.
found that with the beer too. I feel like we were kind of spoiled in Portland, Seattle, Pacific Northwest, and other areas with the beer the beer scene.
I think part of it's the water, right? The
Part
water
of it, I
up
think,
here
is
is
the
good.
probably the water. And I think what is it, like 80 to 90% of the country's hops comes from the Pacific Northwest. And so you're
Yeah.
probably getting things fresher and other things. And for me, I like darker beers. And so here in a really warm climate, there's not, a lot of dark beer. And so
But
that's
just to
part of
clarify, you're drinking coffee this morning.
coffee this morning
Gotcha.
with dark beer next to it. We'll see. My incoherent ramblings may make it tough to tell which one. Um,
Yes.
Well, downfractionpodcast at gmail.com. We keep getting emails. We like those, some topic suggestions, other things that we're working on. Some of the suggestions we feel like we want to have a guest to discuss those topics. So for people who are suggesting topics, don't think we're ignoring them. Sometimes it's just trying to get others on who maybe can bring a different perspective or maybe have different experiences. And so don't think we're ignoring you. It just may be in the works, and coordinating that sometimes takes time. Um, any other stuff? YouTube?
No, I think that's it. You came up with a cute name today, huh?
Yeah, I think we're going to try to embrace our madness, chaos, silliness, old man thing type stuff, and we're gonna go the route of taming the temporalis today.
Nice. Yeah, no, I mean, I know we were talking about ideas. The temporalis and coronoid pathology, I have felt is often overlooked in terms of training and in the consideration of jaw surgery, whether that's TMJ surgery, whether that's orthognathic surgery. I think talking about the temporalis and the coronoid process is pretty interesting, actually. So I like this topic and I like your title of it. So great work.
Yeah, I appreciate the feedback, and I would agree with you. I would even say, from my own perspective, yes, I don't recall dealing with this at all, or it even being much of a discussion in training. And then it really only mostly came on my radar as I transitioned to this current practice that I'm in, where it's jaw surgery stuff only. Because I imagine your experience is similar, and I'm interested to hear it. So beyond just doing orthognathic surgery and TMJ surgery and having to manage it, I do see probably a handful of patients every year who are referred from TMJ problems or are down the TMJ, TMD pathway, who I see them and I see, like you see on your screen, these just absolutely ginormous noids, as I like to call them. And they're physically obstructing the patient's ability to open.
You call
And
them noids?
yeah, I mean, I feel
Sounds
like
like
coronoids is kind of like,
what's the name of the little guys you shoot in Disneyland on the Toy Story ride? I feel like they're called noids or zoids or something like that. But that's what I immediately think of when you say that. I've never heard that term, but I might try it out. I
I
might try
wish
that
you.
out in life.
Yeah, I mean, I think coronoid is kind of an antiquated term. I feel like that's what my grandfather would call these. Um, and I think in the 2025, noids just makes more sense. But back to serious topics. I do see a handful of these a year, and it's sometimes after they've had dental treatment or they've had extensive work done, wisdom teeth out, implants, whatever it may be. And they've sometimes seen non-surgical TMD specialists or facial pain specialists. They've had injections and splints. It's like MRIs. It's just like they're going down the TMD pathway, and no one's kind of really stopped to step back and look at things and say, well, they typically don't have pain. Some of them do, but often they don't have pain, and then their opening is different than the classic TMD patient. It's usually less. There's usually not as much deviation to one side. They don't often have clicking, popping, or even a history of it a lot of times. And so I see that a fair amount in my practice now. Are you kind of seeing similar things?
Oh yeah, I would agree. I mean, extra articular causes for limited mouth opening is always a good thought. And it's one of the good reasons to get a cone beam, right? So the discussion of MRI versus cone beam imaging. Your image that's up there, I had generically learned, and I think this is probably the case, that the coronoid's too tall if it rises above the zygomatic arch. If it's just at versus yours, your image here, that's it's a good centimeter above. I've seen people get cone beams with people's mouths open that actually demonstrate the coronoid process bumping into the zygoma. But I'm not sure if that's all that necessary. I definitely think elongated coronoid process, which can happen from just the pull of the temporalis, but also happens with shortening of the ramus, right? Like
Yep.
as condylar height is lost and condylar neck is shorter, um, the coronoid process is moving up. So I think the consideration of that in the overall picture is useful. Have you had patients for jaw surgery that have that trouble?
You mean post-operatively?
No, pre-op. So their coronoid process is tall, and you're set to do a sagittal osteotomy or a two jaw or something of that nature. And their opening is limited. And you're hoping that when you go to surgery, their mouth opening will relax because they will be paralyzed, and they're still persistently limited by these coronoid processes. So, have you seen that one?
I can't say that I recall that. I mean, I've definitely had patients post-operatively have issues with temporalis coronoid. It's definitely on my radar sometimes when I'm doing mandibular advancements that I want to be, it's definitely sometimes on my radar of is the coronoid going to be in the way of some of the movements sometimes.
Yeah, and our
Uh,
general tendency is to rotate the proximal segment up, right? So everything we were just talking about in terms of change in the condylar head and neck that causes the coronoid process to increase its length, that also can be true in, let's say, a high angle class 2 with VME, right?
right.
So the proximal segment is going to rotate up, and you can even manifest the coronoid process being long in that scenario. I think the situation that it's long going into surgery and they still can't open their mouth, doing a coronoidectomy is a useful adjunct right at the beginning of the sagittal osteotomy, by the way, so that they can open their mouth. First time I encountered that was in fellowship. And since then, I run into it from time to time in that there's coronoid hyperplasia in the setting of the need for orthognathic surgery, whether it's malocclusion or airway or whatever reason we're doing it. And so the release of that coronoid release, it's a fun operation. What do you think? Fun or not fun?
Oh man, it depends on how it goes. I've definitely struggled. Like that image I was just, you can see on your screen. That one, that was a tough one. Sometimes getting up that far with the limited mouth opening
Yeah.
can be tricky. You're trying to get it oriented to remove enough. You're trying to then, after you make an osteotomy, sometimes it's not easy to strip the medial aspect of temporalis off of there. I mean, I've definitely been on the struggle bus with them
Yeah.
before, but it's usually fairly satisfying in that they get better. Sometimes that process is slow, though. I feel like sometimes that's a fairly prolonged PT for some of these patients, but they generally tend to get better.
Yeah, I mean, in terms of the coronoid being long and it's in the way of the jaw opening, um, the inability to open the mouth makes the operation difficult, right?
Yeah.
Like you get a bite block in there, and it's just obviously hard because the coronoid's running into the zygoma. I still think accessing it from below is better than from above. Above's a big operation, so I think running into vessels, fat, and I would say soft tissue medially are probably the biggest tips that I would throw out there. So try to avoid those. So staying subperiosteally will help you with all that. And making sure the condyle isn't cut off. Condyle cut off will make the whole thing quite a bit difficult. So I haven't encountered that, but that's always kind of what you're thinking. It is hard, and it can be disorienting accessing, removing the coronoid process. So
Definitely. Definitely.
anyway, getting back to it, I think the elongated coronoid process was kind of one of the early pathologies, but the temporalis itself can cause trouble. And in your TMD patients, well, you got little surgical pictures here.
Yeah, I was just showing those massive noids that I removed
Those look great.
from that same patient.
Um, let's see, in your TMD patients, so internal derangement, limited opening, pain, those sort of things. I think elongated coronoid process is a little bit unusual. It's great to find it, but it's a little more unusual. Temporalis tendonitis, how much do you run into that?
I think that's a tough diagnosis. Like I don't know that that's a diagnosis that I'm confident making most of the time.
Really?
Yeah, I mean, I have suspicions of it, but I mean, it's almost like diagnosis of exclusion in some contexts. Like, I mean, how are you confidently coming to that? Are you getting MRIs to rule out disc displacements or other obstructive pathologies, or do you feel like you got a good finger on it just based off of what happened? Like, if it's a dental injection or prolonged dental treatment, you feel like that's just steering you that way?
Well, because I mean, it's just a clinical diagnosis in terms of inflammation of the temporalis tendon. It's the patient that when you palpate the ascending ramus intraorally or palpate it on the face, anterior to the masseter, it's just acutely tender, like jump out of the chair tender. And I see that in conjunction with internal derangement. I see it, after exertion, like keeping your mouth open for dentistry. I think it can be combination or an isolated issue, but it's frequently overlooked. Like managing the temporalis tendon, I think in physical therapy, those guys, it's on their radar. But for whatever reason, in dentistry, I think oral surgery is pretty good about it, but maybe still some improvement. Forgetting that there's a tendon that's in that area is easy to do.
For
So,
sure.
um, and I'm of the opinion that the temporalis tendon is one of the bigger causes of limited mouth opening after a sagittal osteotomy. What do you think about that?
Agreed. Yeah, I agree. We talked a little bit about that before we came on, and I think you made some good points about that. Just in general, if you think about it, I think I'll let you talk for yourself about the complexities of it. But if you just think about it, if you're changing the vector of force of that temporalis, the tendon from jaw surgery, I would think that that would have some implications to the situation, whether or not it manifests as a problem or not. But I would think that even relapse might have some effects on that and bite force, mouth opening, feeling like you frequently get the patients that say like they feel like it just feels different or they can't find their bite or other things where I think this could be a contributing factor, if not the sole factor in a lot of those kinds of patients.
Well, I think we just kind of overlook or are numb to the fact that we strip the inferior aspect of the temporalis in nearly every sagittal osteotomy, right?
Right.
And obviously that's different in every case, but the dissection for the normal sagittal split is as you dissect along the ramus, you take off the temporalis, right? I mean, you get the ramus stripper, and particularly if you've got some strong intern hands or resident hands, they're going to be pulling on that temporalis for a portion of the sagittal osteotomy. And you strip the temporalis attachments from the top, bottom, and sometimes you can really strip pretty high. And then post-operatively, we're wondering, mouth opening, it's a bit limited, but we'll get you past that with stretching and massage without kind of realizing that we've just traumatized the temporalis tendon, right? And so kind of considering that and focusing management on the tendon, if residual limitation in mouth opening, I think is a good clinical tidbit.
Yeah, I throw out we often clamp it too, probably, not necessarily intentionally, but a lot of us put a clamp up there to help retract and probably getting some of the temporalis clamped for an extended period of time during the osteotomy on both sides.
Sure. Yeah.
And
I mean, after surgery, you say, they're swelling and limited function because of rubber band use. And obviously the patient's not chewing. But the rehab, mouth opening and stretching, most people do, very well with that once you start kind of focusing on it. But treating it like inflammation of the tendons, so massage, stretching, anti-inflammatory. I think we all understand tendonitis from our, weekend sport activity, or our old man or old woman bodies falling apart. But in the face, we kind of like forget about the temporalis tendon. And so temporalis tendon, whether it's inflammation with tendonitis or tendinosis with chronic inflammation or contracture, I think it's a good thing to keep in mind when you're rehabilitating people following an injury to the jaw surgery, TMJ surgery, all that sort of thing.
So all the modalities you just mentioned, they're pretty much what we would do anyways, right? So someone has limited mouth opening following jaw surgery, whether we identify it as temporalis tendonitis or a problem. Is there anything different you do? I mean, stretching, NSAIDs, massage, all those things we would tell people to do, even if we're not specifically identifying it as temporalis tendonitis. Do you do anything in addition to that when you suspect it's the temporalis more so
Well,
than
I mean,
anything?
when it comes to the reasons for limited opening, masseter is an easy one. Joint internal derangement, I think people kind of jump at as the only cause of limited mouth opening. But there are these other things that are much more common, I think. And so the focus on general rehab after lower jaw surgery is pretty much the same for everyone. But if they have formal tendonitis, like I feel inside their mouth and they're really sore in that area. So they present more as a TMD patient with um, pain on exam. Focusing the treatment on there can be helpful. So, do you do steroid injections into the temporalis tendon?
I have not. And I mean, I was thinking about that and Botox and other things that might be modalities for this, but I haven't done that. Have you?
Yeah, I mean, steroid injection actually, that's what I learned from Spag long ago. That's a nice little button to hit. So, I feel like I did one of those this week. To where someone shows up with acutely painful temporalis tendon, and on exam it's like it really gets them to jump out of the chair. And so you can just use local anesthesia, or you can mix local anesthesia and Kenalog. But I'd learned at least to make 3 injections along the ascending ramus, and that I've used that in TMJ practice to really like hit the pain button in certain situations. That, yeah, obviously in TMD, there's a lot of variability in terms of what's going on, but in the patient that their primary pain is on the temporalis tendon, steroid injection is quick. It gets right to it. If they respond well to it and it comes back, obviously you're wondering about the cause, but the coronoid release is not a terrible intervention. A tendon release would be crazy if we're talking about your hand. Um, but in the jaw, people don't seem to miss it. So
No. That's what I was going to say and I was going to bring up at some point in this is whenever I have these discussions with people about their limited mouth opening, and we're not sure, or sometimes I just kind of explain it to them in a similar context of like, this is a fairly benign way to approach things because if your limited mouth opening is from the temporalis to coronoid and we remove it, then in theory your problem's solved. But if we remove it and it only partially solves it or it doesn't solve it, we're putting you through a procedure. There's cost, there's morbidity, there's risk, there's recovery. But in the grand scheme of things, long term, like we're not removing something that you're going to notice or miss down the road. So like if we're talking irreversible treatment options, this is a very good first step, just even logistically or logically to say, hey, like this isn't it and we're wrong. Really, in the long term, no harm done. And I've had a couple of patients we've gone that route, and that kind of helps them understand and kind of accept the treatment.
I,
Um,
I think the other useful utilization of releasing the coronoid when it comes to jaw surgery is in cases of non-union. If non-union, the proximal segment has been rotated up, particularly for a long time, it is a useful thing to release that just to allow for rotation of the proximal segment back to where you'd like it to be. So, hopefully people aren't doing too many revisions or non-union repairs in terms of ramus or mandible osteotomies, but I
I
think
mean, if
that's a sneaky adjunct in there too.
they practice near you, they're going to be seeing it. time to time. When you say you do the 3 injections or 3 points of long day ascending ramus, are you doing that intraorally or extraorally?
Intraorally.
Okay. So you're just kind of
Yeah,
numbing them
so
up on the lateral ramus and then injecting either Kenalog or a mix of Kenalog and local.
yeah, Kenalog and local tends to be the mix, so it's just one-to-one marking. I know there's a group of people like oral facial pain people, use these sort of tricks frequently. Just in surgery, we don't necessarily learn as much as we should from that group of people, and so there's some good tricks in there. And so steroid injection or even local anesthesia injection into the temporalis when it's inflamed can be a helpful thing.
Okay.
The another I think you were talking about it, but another consideration in terms of the temporalis is the side to side motion, right? So we were talking about superimposing results. So superimposing your postoperative result to the pre-op. And I'm trying to get you to do that sort of thing more regularly. I got into that when I was a fellow, and the location of the temporalis seems to be quite variable. So I'm sorry, not the I infer the temporalis, but the coronoid process seems to change quite a bit. And you can't terribly control that. And there's crazy situations like asymmetry where you're moving things over, 15 millimeters. Or, there's big rotation of the proximal segment because of, let's say, hemimandibular hyperplasia case or something like that. Where the consideration should be had post-op if they're limited that the coronoid process is too close to the zygoma or the vector is kind of causing movement trouble. So I don't know. I would put out there is if it's a really big movement or anything crazy going on, that at least considering that the coronoid process is a different spot than it used to be, could be contributing that to trouble.
Do you think the temporalis reattaches when we cut off the
Oh,
coronoid?
sure, right? I mean,
Yeah, I would think so.
um, I feel like we're jumping around a little bit, but in TMJ replacement world, one of the things you can bring up, it's like do you use screw fixation or plate fixation in the mandible and jaw surgery discussions, right? In TMJ replacement world is, well, do you take the coronoid process or do you leave it, right? And it's a there's I don't I would say both answers are right. There's clinical situations where it's reasonable. I know people who are concerned about taking the coronoid process increases your rate of infection to the maxilla when you're doing a Lafort and TJR. I know people who always keep the coronoid process to help out with dislocation risk after TJR. Um, I think it depends on what you're doing in the overall picture. Um, but I think I'm like you, where I tend to take it most of the time. So, and you see people back and they start growing new temporalis or new coronoid process, and so it's not like the temporalis atrophies entirely; they regain some function. Um, so I have to believe it reattaches.
Yeah, I recently had to re-enter some joints. I mean, when you do that, when you revise prosthetics or two-stage things, do you look then? Because I recently looked and it seemed like in the course of about 3 to 4 months that there was some reattachment to where I'd already taken off the coronoids and I kind of restripped it again.
Yeah, because I mean it's probably different, right? So it's probably just scar tissue that you know is allowing it to reattach. But um, I think there's some function that regains. The 3 or 4 month one, I don't know if I can speak to as much, but I mean it makes sense for it to start functioning again. So I don't know. I think coronoid's easy to overlook. And it's like you learn in mandible fractures, oh, coronoid fracture, no big deal. Um, Kind of think about all the other things like masseters and internal derangement. Um, but I do think there is a consideration. I bet you there's some both anatomic subsets and then postoperative trouble subsets that would argue that the temporalis is playing a role in their overall picture. So
Yeah, and you're the opinion that on an evolutionary basis, anatomical basis, you don't even think we should have a temporalis, right?
no, I don't think so. I mean, I don't know on that one. Why are you hating on it so much? It's not like a wisdom tooth. I'm joking. Wisdom teeth are great. Um, No, temporalis seems to be useful. It's just
You don't, you don't need it. Just
people don't
problem.
seem to miss them too much.
Just a problem. I mean, I know they're out there developing techniques to inject tooth buds for wisdom teeth removal. I wish they would just do that in infancy with the temporalis. We just don't need it. It's only a problem.
I I don't know. It's like anything. It's probably best to be left alone unless it's obviously causing trouble. I think you had mentioned earlier the dental injection part. I think that's the other sneaky one on temporalis, by the way, and probably most of our listeners know this. But I learned in dental school with injections, if you're doing a mandibular block and you give 2, 3, 5, 10 injections, because they're not getting all that numb during your crown or filling or whatever you're doing. Um, that if their mouth opening is limited, it's a hematoma of the medial pterygoid. Is that what you learned?
Yeah, or hematoma in that area, the, pterygoid, medial pterygoid space, or, I'm not trying to badmouth anyone, but I think it was just like you're getting a hematoma in the area, and that was about as much as was described. I don't know that there was much more detail than that.
And as you've gone on into practice and done jaw surgery and kind of dissected and operated in that space, do you still have that opinion, or has your opinion changed?
I wouldn't rule it out. I mean, to get a hematoma, it would
Hmm.
have to be a confined, somewhat confined space. I guess it kind of is. But you'd have to hit something fairly vascular. Like you'd almost have to hit the vessel, the IA or something in that area, would you not?
I suppose I feel like there's enough space for a blood clot to go elsewhere,
Right,
and I don't frequently think that's a trouble in, let's say, jaw surgery. And jaw surgery causes way more bleeding in the medial aspect of the ramus.
right.
Not always, but largely in Arizona. But what is there is the temporalis tendon. And I don't think it's unusual to be bumping into that thing. People that I meet, patients who have persistently limited mouth opening after a dental visit, and they come and see me because they're concerned about internal derangement, right? They're worried that the disc has slipped. I wouldn't say always, but frequently it's temporalis pathology. And so just meeting those people and treating their temporalis, whether it's steroids, whether it's coronoid release, um, that seems to be the right approach for most of those people, which would argue that the temporalis is the problem with injections. And it's not saying that, the medial pterygoid hematoma isn't a disease process that, I assume it still can be, but I remember looking into literature on this stuff, and it seems like it's just temporalis pathology, the whole thing. So I don't know. I put a plug for that. Not that that changes anyone's life, but if you do run into that, and obviously referring doctors or in our own practice, um, whether it's wisdom teeth or jaw surgery, inflammation of the tendon, limited mouth opening, development of tendinosis, it's a real thing. So
Do you have like a pathway that you go with those people? I'm sure it's dependent. Like if you just encountered that in your practice, they walked in, if they haven't gone to physical therapy, are you trying that route first? Are you trying
yeah,
NSAIDs and stretching on your own physical therapy and then say, hey, come back in X amount of time? And if it's not better, we're going to try steroid injections and then further physical therapy. And if it's not better, then we're going to take off your coronoid. Or like, do you have a pathway that you put them through?
definitely physical therapy before I start stabbing them with anything, particularly because the stabbing of things kind of caused the trouble in the first place. So let's get you some stretching, see if you can rehab on your own. And honestly, most people, by the time I'm talking to them, have done that stuff anyway.
Right. That's what I was
Uh,
kind of getting
and so in the situation of they've already tried physical therapy, steroids, I just don't think there's lots of downside to it in that location. And you know, have you treated a lot of those patients that have limited mouth opening after injections or after a root canal and just kind of
fair
sticks
amount.
around for a month or
Yeah,
two?
fair amount.
Um, what do you think? It's a tough one in terms of TMD trouble.
It is. And I would say, again, this is not meant to be negative, but I think part of the trouble that I run into, and maybe your situation is different, is they do, as you kind of just said, they think they're on the internal derangement or a TMD pathway. And so sometimes convincing them, which maybe isn't the best word, but like discussing with them that, hey, maybe it's not, because they'll have seen sometimes their dentist who says it's a TMJ problem, and then they'll see someone else who says it's a TMJ problem, and then you're
Yeah,
trying to re-educate them, and sometimes they're resistant to that too.
because it might be, but
Yeah.
those are the situations that I kind of find myself on a choose your own adventure surgical path, right? Like I'm nothing on the MRI, CT doesn't really show much, but they're hard stop 15 millimeter opening. And it's like, well, let's do an exam under anesthesia and then kind of take it from there, whether I put a camera into the joint or whether we release your coronoid, to their perspective, it's I really want the mouth opening to get better. Um, that crew, it seems to be releasing the tendon is the answer. So I don't know. I used to start with scope, but when people can't open their mouth, scope is really hard. Um,
I've done that too. I've gone down that pathway, and then after the fact, kind of been like, ugh. And I ended up taking their coronoids, and it's like
yeah,
I don't know that that's the right or the wrong thing to do. I mean, I'm a big advocate for arthroscopy for that reason, because I feel like, finding things and not finding things both have value. And if you're not sure if it's TMJ pathology, a good, somewhat benign, minimally invasive way to kind of rule things out is to put a camera in there and look around.
yep.
Um, but, you know,
And obviously there's other reasons why the mouth opening can be limited than the two things we're talking about. So, still manage the masseter, still manage whatever calcifying of the muscle is showing up, those sort of things. But anyway, I would no discussion of temporalis pathology, I think, is complete without commenting on injection trouble with dentistry. So I think that definitely happens. Um,
I feel like I was going to say something else, and now I forgot what it was. Ugh.
I don't know. I don't know if I have too much more to say about temporalis. I think it's an interesting area going forward, and I'm always on the lookout for learning more about that thing. So
Don't need it, man.
what's that?
Don't need it. It's like a vestigial tail. You don't need it.
Your vestigial tails is one of your redeeming features.
It
Kind
does
of
kind of
helped
go,
you out in life, right?
it goes crazy when I get excited. Um, I mean, oh, I remember what I was going to say. I mean, I was going to say kind of along the pathway of it could be, TMJ, coronoid, tendonitis of the temporalis, whatever you want to call some of these things. But I mean, it's as Bell used to say in his Southern accent, patient can have as many diseases as they pleases. And so sometimes it could be both, and you're trying to sort things out, and it's not one or the other, it's one and the other.
Yeah.
And so it can be tricky.
Yep.
Does that
Yes.
count as our old man saying, or do we need to?
I think it's great. Diseases as he pleases. That's a good one. So
You don't remember him saying that, or did he ever say it to
I mean, I feel like it. Definitely busted out the southern accent from time to time. Trying to think. Bell sayings. I feel like that's a good one.
you? Yeah, I remember Mike. Patient can have as many diseases as it pleases. It's like, all right. I mean, he's right. It's a good way. It's a good way to
And it
think
sticks
about
with you,
things.
right?
What's that?
That saying sticks with you.
It actually does. I mean, and it's very true. I actually frequently say that to patients. I say I used to have a attending who said that, and so we need to be sure. And sometimes it is situations like this where the symptoms and the imaging and the exam, like everything's not adding up. And frequently I find that it's sometimes that subset of patients where you can't explain anything, and they're a little bit older, they have a history of malignancy or other things, and you're the first one bringing up the possibility of like there could be a malignancy here or something we're not seeing. I think we need to get more imaging. I feel like I've used it in that patient subset before, like they're referred for something, and you're like, this is a little odd. Some of the symptoms you're saying are concerning. And while you might have the TMD issue or whatever they were actually referred for, let's not miss some of the bigger, more potentially catastrophic possibilities. I mean, I'm sure you run into that too.
Yeah, no, I mean, being curious and kind of keeping an open mind is crucial in clinical practice. And it is easy to get lulled into seeing what you're used to seeing. But if it's a cool old man saying that you heard in residency, keeps you fresh to think about possible alternatives. Hopefully, our conversation on temporalis at least put the bug in someone's ear that temporalis could be part of the problem for the next person they see. So, hope to play a little bit of role in that sort of thing. But you were right to say that it is multiple buttons, and some people, ideally, it's one, but it can definitely be multiple. So,
I'm definitely when I take out my kids' wisdom teeth, their coronoids are going too. Like I'm just not messing around with this.
I feel that seems a little extreme. Um,
Get on
well,
board.
sweet. We have Labor Day next week, so probably later in the week again for podcast. You doing anything for Labor Day?
I mean, just being awesome like always. Nothing too special though.
When does it
You
cool
do
off in
anything?
Arizona? Labor
What's
Day?
that?
Is it like 2 months from Labor Day? When does it start not being 100 degrees?
We got some rain actually, which is weird. Got a massive haboob or dust storm, which was all over the news. I don't know if you saw that.
No.
It's kind of impressive. You need to get out of your
It is.
bubble, man. Um, it's only 94 right now.
Oh, great.
Yeah, a little
Well,
humid though.
that sounds lovely.
Do
So,
you think we tamed the temporalis?
Temporalis taming us. I mean the topic for sure. I feel like if anyone that has any other tidbits or some useful temporalis advice, we'll pass that on. So shoot us a message. Otherwise, I think we've talked this one to death. So
We beat the dead horse
get it
again.
tamed.
All right, cool. Well, that was another Down Fracture podcast, a podcast for Talking Jaws. Check us out on YouTube, Instagram, wherever you want to see it. We do sometimes put some visuals up here that might be useful, but maybe not so much. All right, till next time, Sam. I'll see you later.
Sounds good. Have a good rest of the day.
You too.